Kalimera σας. Hello, good morning. Can you hear me, Dr. Boudris? Is everything okay?
Yes, that's okay.
Can you see my slides?
Yes.
Okay, thank you very much. I'll go quickly due to the time limits. Thanks once again the organizing committee. And let's go to focus on a population that we never focused before. Young patients less than 65 years old. Of course, as you know, we'll have new guidelines in 2025 regarding the treatment of the patients. So from all things are running very fast, and we'll have vulvar heart disease new guidelines along with other changes in just 3 months. So we'll have new data very soon. We know that whatever you do it in a good valve center of excellence, not in an environment without very much experience. And we know that we started very early with very high-risk patients, inoperable patients. We proceeded with high-risk patients, and then at the end of the decade, we went to the low-risk patients. However, over the age of 70, 75 years old. And lately, we have some data regarding very young patients. The mainstreams that changed the guidelines during the last years and will change the guidelines in 2025 are these two landmark trials, the Partner 3 and the Able low-risk patients, which were the first patients in low-risk patients. However, the mean age was more than 70 years old. We know the favorable results of TAVI compared to the surgery in these populations. I don't see something new in both valves, also with the balloon expandable, also with the self-expandable. And we have also at 5 years, we also know that these results are maintained compared to the surgical part. And at 5 years, we don't have any difference in any component of the primary endpoint in the low-risk patients. Also, TAV was associated with a reduced risk of mortality in a meta-analysis compared to the surgical treatment across all spectrum of the patients. However, we know the guidelines, we know the clinical practice is different. Just a month ago, just some days ago, we had these very nice publications from the United States of patients that they identified 2,360 patients aged less than 60 years old, and they included patients with TAV and SAR. So what they did show that, firstly, between 2013 and 2021, the patients that underwent TAV were increased from 7.2 to 45.7%. So there was an annual increase of 4.7% each year. That means that, according to the clinical practice, almost half of the patients less than 65 years old are going to the TAV group. Are the results favorable? You can see that the mortality 30 days is comparable between these two procedures. The reoperation at 5 years is less than in the TAV group. Endocarditis has no difference, and the stroke has no difference between these two groups. So it seems that the only worst thing was at 5 years that there was a significant increase in the 5-year survival. However, all patients less than 60 years old had a worse clinical profile and more increased STS risk score. So the comparison cannot be done prospectively, only retrospectively. This is another trial, again from the same group, published just 2 months ago, and they saw that less than 65 years old with aortic stenosis, again increased gradually from 7 to 54%. And after propensity score matching, and this is the key point, the 30-day mortality was similar between these two groups. And also the TAV group had a higher 6-year mortality, 23 versus 10%. And how in all other sub-analysis, there was no difference. And when they saw another group published just 3 months ago, the outcomes of balloon expandable valve in younger patients in the low era, they saw that the mortality at 1 year was comparable between the two groups, and the readmission rates were the same. So patients younger than 65-year olds had a worse baseline quality of life, and also all the parameters were worse in this young population. So we don't have many data. There were many data. However, the most important thing is that they are not compared because the lower age group in the TAV group had a higher risk profile, which was not comparable with the surgery group. There are open questions if you go to the low risk, to the young patients. Valve durability, bicuspid valves, we already heard from the two speakers before. The procedure that you have to treat after that with valve in TAVI, coronary access, lifetime management. Of course, there are several parameters that we have to decide before we proceed with the TAVI, especially in the young population group. The durability seems, at least in the low risk group, exactly the same between the surgical and the transcatheter valve implantation, and maybe the biprosthetic valve failure may be favorable with the intervention group. However, we can also accept that there is no difference between the surgical and the TAVI group. Dr. Stathogiannis has already shown that the long-term performance is favorable in terms of cardiovascular mortality in a very high-risk population, not in survival, because there was very high-risk population in non-cardiac deaths in this group. So we have some indirect data, and this is a patient 70 years post-core valve. We did yesterday the echo without any signs of valve dysfunction. So we have some promising results of patients living really 10 and 15 years post-TAVI, one of the first patients that we did, with favorable results. As I already told you, there are several questions still regarding these patients, and we have to know how to treat these patients when they come back. So we have now a significant population, not significant, but there are some patients with valvular dysfunction after TAVI. You can see here there is a biprosthetic failure with mean gradient of 34, failure after TAVI. So we have to treat this patient. You can see that jet in aortic regurgitation post-TAVI implantation. So we have to treat with him with a new valve in TAV with a favorable outcome after the procedure. So we have a new population that is coming in our cath labs, and we have to decide which is the best method to treat all these patients. And the strategic intervention starting from early in life, and we have to administer that, and we have to treat this patient in a second and possibly 3 times. We have 3 trials regarding the treatment of early intervention in these patients. I don't go to the details. I just mentioned that there are not advantages regarding the early treatment of these patients. Of course, the TAVI unload, and we have evolving evidence with new valves that are coming in the era of transcatheter valve. One of these is the landmark trial that we also participated, showing that we have new modalities that will have the same clinical results, and they are promising regarding the technical results. We have also a study running regarding the conservative or the PCI treatment in these patients. Until now, the meta-analysis has shown no difference between the PCI and no PCI between the two groups, although in the secondary points there was an increase in the bleeding at 30 days in the PCI group. We have the elective and the non-elective these patients, and we have experience in some patients, especially in young patients with radiation. This is a patient with breast cancer, radiation therapy, surgery, 2013, low Euro score, however, she had a severe AS. and we had to treat this patient. Of course, everything went good. However, we have to anticipate the future, this patient, the long-term survival, and the second or third time treatment. Of course, the valve disease, the prevalence, and the unmet need has really increased, especially in the aortic stenosis and also in other valvular populations. There are more and more patients coming for TAVI, especially young patients, and I would like to thank you for your time.
Thanks so much, Professor Toutouzas. And I would like to invite the last speaker.